Hello and welcome to our review of the lupus literature from April. We're going to be recording these podcasts every month, so you can always keep up to date on the latest literature and expert opinion to go along with it. My name's Ed Vital. I'm at the University of Leeds and I'm chair of the Lupus Forum, and I'm joined today by Professor Victoria Werth. She's Professor of Dermatology and Medicine at the University of Pennsylvania and Chief of the Division of Dermatology, University of Pennsylvania and Philadelphia Veterans Administration Hospital. Welcome, Vicky.
It's great to be here, and these are a great month for reviewing these articles.
Yeah, we've got quite a few strong and interesting papers that I think generate quite a bit of debate this month. And so the first one is one that I took a look at, which is about CD19 CAR T therapy. So I think most people have heard at least this mentioned, CD19 CAR T therapy. If you haven't, where have you been? Because it's been everywhere at the conferences. But it just, to bring you very rapidly up to date if you haven't, the idea, this is about B-cell depletion. We've done B-cell depletion for 20 years with rituximab, and then with some more follow-on drugs recently, which are monoclonal antibodies that target CD20 and kill the B-cells. And it's been known for a long time, actually it was part of my PhD back in the day, that rituximab doesn't actually completely deplete B cells in all patients, and that's one reason why it doesn't work. Probably not the only reason, but that's one reason why it doesn't always work. Sometimes works great, sometimes doesn't. So in oncology, where they were trying to use a similar strategy for malignancies of B cells, lymphomas basically, one of the approaches they developed is, instead of using a monoclonal antibody, use a T cell whose T cell receptor has been re-engineered to target CD19, which is similar to CD20, like an antigen that's expressed on most B cells. So patient has the T cells harvested. The T cells in the lab are re-engineered to express a T cell receptor, so they target B cells. Then the patient has fludarabine and cyclophosphamide conditioning, quite significant chemotherapy agents for conditioning in this population. And then these T cells are given back to them, CAR T cells given back, which cause B cell depletion. And the claim is, because it depletes deeper, you get a more complete immune reset, and therefore you can induce a very long-lasting remission without any other immunosuppressants. And people even say this is going to cure lupus. So before we get too excited, we're looking at case series. So there have been a couple of papers from a group in Germany which are published an initial case series of 5 patients and have gradually enlarged it. And this is one of those. So here we've got 15 SLE patients, 3 patients with inflammatory myositis, and 4 patients with scleroderma who had the regime that I just described. They've shown B-cell depletion. The B-cells came back after about 112 days, 4 months, which actually, compared to monoclonal antibodies, is not a particularly long period of depletion. They're coming back. There aren't the kind of assays that you'd need to compare the depth of depletion between, say, rituximab or obinutuzumab or ianalumab with CAR T-cell mediated depletion. Those haven't been done here, and neither have we got depletion measured in tissues. But they do show long-lasting responses. It's described as up to 24 months. So it's important to note that that's the longest. Most of them are quite a bit shorter than that. And patients seem to respond quite well. So what can we say about this at this stage? Obviously, it's only a case series and we need more evidence. There are an awful lot of different research programs in progress. I think there's a couple of things that I was quite positive about. One is that the normalization of the autoantibodies was shown here, and it appeared to my eyes to be quite good. So most of the autoantibodies were becoming negative, which is not what we usually see with rituximab. A notable exception to that was row 60. Another positive I thought here was that there are some significant concerns about safety with CAR T therapy. And two of them are around the time of giving the infusion. You can get a kind of cytokine release syndrome, which can cause, like a serious illness that needs treatment in intensive care, and is often treated with tocilizumab. So here, they only saw that in a few cases. In most cases, it was mild, like a low-grade fever. 11 patients got something. 6 of them had tocilizumab. 1 was moderate grade. So that doesn't seem as bad. There's another thing that people have reported with CAR T therapy, which is a kind of neurological syndrome, which again can be very severe, called ICANS. Here, they only had 1 case that was described as having it, and that sounds pretty borderline. It was just somebody with a bit of dizziness. It wasn't things like seizures and coma that have been reported in the most severe cases. So those are 2 pretty good things, I thought, from this report. But I think there's a couple of things I'm a bit cautious about here. Obviously, it's a smallish report. Most of the patients here hadn't previously had rituximab. Some had, but many hadn't. So how do we know this is anything more than you'd get from more conventional B-cell depletion strategies? We don't have evidence of greater depth of depletion. We don't have evidence of more longer-lasting depletion, and we don't have some kind of comparison. It's not like you've got somebody who failed to deplete and respond to rituximab, and then got depletion and response on this. There wasn't anything like that. And then the other thing, I suspect you're probably going to share my view, is that maybe conceptually, the idea that just depleting to a deep enough level is going to undo everything that causes lupus pathology is a bit too simplistic. I don't know. What did you think?
Well, I think we have a lot yet to learn about this technique. And I think, yeah, I mean, I'm a little concerned that it will not be long-term, but again, we're going to need much longer data. It's certainly very exciting to see these kinds of papers, with actual cases that have done quite well in the short run. I also think it's a pretty labor-intensive, rather expensive at this point, approach. And so the types of cases that may in the long run be amenable to this, we have to be fairly carefully selective, but also recognizing that this is a rapidly evolving field and that the technology may become a lot simpler. So I think we're at the very early stages and we have a lot to learn.
Yeah. So I'm unsure because lupus genetic susceptibilities either in the innate immune system or not in the immune system at all. It's to do with like cell death and clearance. And so I'm a bit unsure as to whether any B-cell depletion can undo all of that and whether eventually everyone will relapse. I think that's a significant concern, may or may not. I also think, like you say, okay, it's expensive. What is it? I mean, if it really did cure you, then you might say it's worth going through all of that, especially if you've had more severe and resistant lupus. But I think we need to be mindful that the other B-cell depleting options are getting better. So if you take something like ianalumab, that's enhanced depletion of B cells, it's subcutaneous. You just do it at home every 3 months. It's a lot easier. And so the bar to beat it is getting higher. So I think it's a watch this space. It sounds interesting. It's positive for the general field of B-cell depletion, but I think a lot more needs to be learned. And at that point, we should probably go on.
All right. Well, I have a very interesting paper that I'm planning on reviewing. And this has to do with a drug that I think has really, to some extent, revolutionized a lot of what's being done for certain SLE patients. And in particular, we know that this drug is anifrolumab. It blocks the type 1 interferon receptor. And it has been in a number of trials that have been TULIP 1 and TULIP 2 to be specific, that have demonstrated improvement in SLE. And some of the studies have been done are starting to look, and in particular this study, at the pathways that are involved in gene expression and proteomic analysis by pooling these 2 phase 3 trials and looking at samples from the blood. the TULIP-1 and TULIP-2 studies, there was whole blood expression of a number of genes analyzed, and these included 18,000 genes to be specific. And they looked at patients who either got anifrolumab or placebo, and they also looked at plasma proteins and using Olink and Simoa panels. And what we know is, again, that when you block type 1 interferon, there's going to be a lot of downstream kind of effects. And this really is looking at what specifically was seen. And in particular, one has been able to observe that a number of genes, in fact, a very large number of genes, are downregulated when patients have been exposed to anifrolumab. And in particular, genes related to interferon alpha were suppressed by the JAK-STAT phosphoninositide 3 kinase pathway, and also NF-kappa B, and also via MAP kinase. And in addition, there's effects on interferon gamma genes as well. And so this is all extremely important, I think, to realize and to understand how many aspects of the immune system are being reset when you block these, specifically this receptor. So, Ed, I'm curious to see what your thoughts were about this study.
I mean, I think it's the whole question being asked here is fascinating, isn't it? Because, compared to the previous paper, we say B cells, we think we've got some pathogenic clones of B cells that are making autoantibodies, and that's how targeting B cells works. But interferon targeting, such conceptually so different, isn't it? You're targeting innate immunity, and I think of that, I may be wrong, but I think of that as being kind of upstream of the adaptive immune changes. But also type 1 interferons have very, very widespread effects on the immune system, and which of those are the important ones? So yeah, I thought we're seeing some things that we would expect, like plasma cells going down, maybe some things that we didn't necessarily know, apoptosis, netosis going down. Mostly beneficial things, I think we have to say. The other thing I noticed that was shown quite clear on this paper was lymphocyte count improving or increasing back to normal levels, which is an interesting finding. I think it's very strongly seen with anifrolumab therapy. And of course, the rates of infection, apart from herpes zoster, are quite low with this treatment. And you just wonder if there's some kind of restoration of overall immune health reflected here.
Yeah. So I think we'll see more and more of these types of studies. This one really was very complete, I think, in many of the analyses that were done. They did in silico RNA-seq deconvolution, and again, looking at cell type abundance. So they were able to really pinpoint many of the changes comparatively with the placebo group. And so, yeah, I think this is really very interesting and pretty effective. Explains some of what we're seeing with the clinical studies.
So shall we go on to the next paper now? So
Absolutely.
This one, I had to take a look at this one. This is an interesting paper. It's kind of preclinical, really, but in terms of a new therapeutic approach, it is, again, very interesting. This is by Eggenhuisen et al. It's from Josh Ui's group. He's at Monash in Australia, published in Nature Communications. And this is about Smith-specific regulatory T cells. So in other words, it's a therapy that tries to induce immune regulation rather than immune suppression. So Smith is, of course, an antibody that's associated with lupus nephritis and with more severe forms of lupus. It's also HLA-DR15 is associated with that antibody, with that presence of that antibody very strongly. So there may be some causal link between having that HLA haplotype and developing that autoantibody. So what they've done here is they've identified, through quite interesting and complex methods, identified a T cell receptor that is HLA-DR15 restrictive and has high affinity for the SM or Smith antigen. And once they've identified that T cell receptor and its sequence, they can then transduce that into patients' Tregs so that you generate Tregs that will target and cause immune regulation of a particular autoantigen. So it's another kind of T cell engineered cellular therapy, a bit like the a bit like the CAR T CD19 we talked about. And in this paper, a lot of the paper is about the generation of that product, but then there are a couple of pieces of evidence to show that this might really have benefit in treating patients. So some of it is what's shown on the slide there, which is our in vitro suppression experiments. So in other words, if you take polyclonal Tregs, that's regulatory T cells that might be regulating against any antigen just naturally occurring, which are the ones shown in blue, or these Smith-restricted Tregs, or none, you can see this suppression of various immune responses like IL-2, IL-10 production, tolerizing DCs, lysing inflammatory cells, all of the things that we know Tregs can do. A lot of that was seen in these experiments: more IL-10 production, less interferon gamma production, less IL-17A. And then the other thing they showed was an animal model of lupus where the animals were treated with these Tregs, resulting in less proteinuria, less histological inflammation, and tubulointerstitial injury in the mice. So it seems quite promising. The interesting thing about therapies such as this is that because they're not causing immune suppression, they may work in different people, would have different they may have better safety, or they may work in combination with the other therapies we've got. Like, you can imagine an approach where you give immunosuppression to get someone into remission and then try and regulate their immune system with Tregs or something like that. So it's just conceptually very different. The next stage is to develop a product of a standard that can be used to actually treat lupus patients. And again, that sort of process that needs to be followed is outlined in the paper and also shown on the slide here on the left, a little cartoon about how that needs to happen. So I thought very interesting, preclinical at this stage, but interesting to think about.
Yeah, no, I totally agree with your thoughts about this. And I think this emphasizes the many different cellular approaches that are being taken to try to deal with lupus. And I think we're going to see other approaches. This is certainly very scientifically, rigorously produced and very specific. And I think it will be very interesting to see how relevant it will be to given all of the heterogeneity that we know in lupus. But I think, again, with the idea of different off-the-shelf products that will be able to be given to patients that may modulate their lupus, I think this is a really interesting approach.
Yeah, and actually, thinking that we've talked about two kind of cellular therapy papers, I sometimes I think that using CAR T cells to target CD19 may be a bit of a blunt approach to lupus, and it may not be enough to normalize all the complexity that we see in patients. But I think when you take these two papers together and some of the other things I've seen going on in the field, the interesting thing is that the entire field of cellular therapy is moving forward all at once. The different technologies that can be used, the variety of the approaches, knowing how to do the clinical trials and roll cellular therapies out into the clinic is an important emerging field as a whole.
Totally. And it's really requiring teams of physicians working together because there's such a wealth of experience, for instance, with some of the cellular therapies in oncology. And so I think that's also an important element of this.
Yeah. Okay, let's go on to the next one.
Okay. So we now have a study that's having to do with the cardiovascular risks of lupus in particular, and we're looking at comparing. It's really a meta-analysis that's examining a number of studies. There were 186 actually eligible studies, and that have been looking at the issue of cardiovascular risk and its management in SLE. And in this case, they looked at articles that were related to lupus with or without lupus nephritis. And so they were able to really contrast some of these aspects as well. And they looked at various outcomes that are prevalent in lupus patients, such as MI, cardio, and then also strokes, hypertension, hyperlipidemia, plaque occurrence, and looked at various aspects of hyperlipidemias as well. And so this is a important study, and was also looking at what are the elements that are elevated relative to to normals. And in fact, they found increased systolic pressure, blood pressure, increased diastolic blood pressure, increased hypertension. Also looked at, and we know that all of these factors are really important in terms of cardiovascular risk. And in addition, they looked at total cholesterol, LDL, really all the sub-factors as well. And again, showing differences in patients with lupus nephritis relative to lupus in some of these aspects and things that are risk factors for, such as, again, hypertension and hyperlipidemia. And so they were again able to show that the patients with lupus nephritis had higher, rather significant increased risk of MI, CVA, and plaque relative to SLE patients. And so the conclusion is that lupus nephritis patients in particular are at risk, even though we know that SLE patients overall, but the nephritis patients especially at more cardiovascular mortality, and that it's really important to address these risk factors in a timely fashion to try to prevent all of these increased risks that we're seeing in these patients. And that's sort of the summary of what was found here. I will say that as we learn more about controlling risk factors, and it does seem that some of the lupus patients are more like diabetic patients, even if they don't have diabetes in terms of their risk, that we're going to need to become very more aggressive at managing their risk factors than what was happening currently.
Yeah, that's right, isn't it? The hurdles in the lupus, we get better at treating inflammation. We have more of a problem with treating some of the other causes of morbidity and mortality in lupus, which becomes a greater focus. I noticed they made one interesting comment they made in a couple of places, I thought, was that you think of in a non-lupus population, you think of certain groups of having higher and lower risk, like ethnic groups or age and sex and things like that. But that tended to sort of get ablated by lupus nephritis, that once you've got nephritis, you've just acquired the risk of lupus nephritis instead. The other thought I had reading it was, I was kind of asking myself, how much of this is due to the steroids causing all of these effects, or how much is due to the disease itself? Because can we avoid some of these effects by using other drugs and reducing the need for steroids? And I found it a little bit difficult to understand that, actually. I don't, it's hard to understand from this sort of study, isn't it?
Yeah, no, it is. Although I have to say some of the hyperlipidemic types of aspects seem to have been modified by anifrolumab. And so one might, potentially think about that some of the approaches we're taking are going to have some downstream effects. But I think that we need to be much more rigorous. For instance, there's so much better management of LDL, which is really a driver, as opposed to HDL in atherosclerosis. And some of these newer drugs, the PCSK9 inhibitors, can very rapidly decrease the LDL levels to, in the case of people who have known heart disease, they should be really at a level of 50 or lower. And so we're not really managing at that level. And often I find it helpful to work with preventive cardiologists, not the cardiologists who are treating disease, but trying to prevent the disease. And that's been really important for, I think, being able to apply some of these principles.
Yeah, so in terms of in the clinic, we have to firstly check and address these risk factors in the way that you normally would do for anybody, by treating blood pressure and cholesterol, etc. But also in the future, we need to look at these trials of new therapies and see if how much these new therapies are able to lead to these other benefits as well, not just reducing inflammation.
Right.
Okay, and then the last paper is one that came out in Lancet Rheumatology about withdrawing mycophenolate. So this is a question I get asked all the time in clinic, which is people saying, I feel quite well. I felt quite well for a few years. Can I stop some of these treatments? And it's probably one of the things where I often have the most disagreements with patients, actually, because I'm always saying things like, well, I can see perfectly well. Shall I stop wearing my glasses? Um, and yeah, but without being facetious, there is a massive unknown here, which is that there are clearly some people who can come off. Lupus has calmed down a bit. They can come off their immunosuppression, but there are other people where if they do that, they're going to flare. So it's a really difficult question to answer, and we're always feeling our way. So we need trials, and this is one. This is a randomized controlled trial that was done quite formally and quite carefully. There's one previous randomized controlled trial looking at a similar question that we looked at recently called Win Lupus. There was a study done in France that was about stopping mycophenolate in people with lupus nephritis 2 to 3 years after their lupus nephritis. And the conclusion of that study was that if you stopped treatment after 2 to 3 years, there was an increased rate of flare. So it was not really advised. So what do they do here? So here, this was another randomized controlled trial. Quite a lot of the patients had nephritis, 76%, but not all of them. So they had 102 people randomized to either continue mycophenolate or to withdraw it, and then they were followed up for 60 weeks, looking for disease reactivation that was measured in a few different ways using SLEDAI and BILAG criteria. And the bottom line, just to cut to the primary outcome, was that they didn't. It was a non-inferiority study, and they found that non-inferiority was met. In other words, there was with the withdrawal group, 9 patients or 18% had a disease reactivation, and in the continuation group, it was 5 patients, 10% who had a reactivation. So there is a small, numerically higher rate of reactivation in the people who withdrew therapy, but in terms of their statistical power and their statistical model, that was considered non-significant. What else can we say about that? There were a couple of other things. The safety data were quite interesting. So overall adverse events, there wasn't any difference between the two groups. But when you looked at infections, they were more common in the people who continued mycophenolate. And it was 64% in people who continued mycophenolate, 46% in the people who stopped. So a fair difference in rates of infections. And when you looked at serious infections in the people who continued mycophenolate, there were 6 serious infections in 4 people. And in the ones who withdrew, it was 1 serious infection in 1 person. So that does seem like a benefit associated with withdrawal, possibly balanced against a slight and non-significant, so uncertain risk of reactivation if you stop. Then I looked a little bit about anything about the population that's obviously important to think about. So this was a study done in North America, so the demographics of the population kind of reflects North America. So there was in the 2 groups, it was 31% or 49% who were described as white. The rest were mainly described as a North American Black ethnicity, 20% Hispanic, and relatively small numbers of Asian or other ethnicities. So these things obviously correlate with flare rates and with nephritis. So that might be significant if you're working in a region that has a different grouping. About 39% were on prednisolone, most of which was less than 5 milligrams. Mycophenolate duration. So the median here was 5 years, so this is clearly longer than the Win Lupus study. 25% of patients, it was less than 3 years. 25% of patients, it was more than 9 years. And for the other half, it was kind of between about 3 and 9 years. So longer duration on mycophenolate. And disease activity, SLEDAI, the median was 2. But I thought more notably, they also quoted how many patients had any BILAG A's or B's, no A's, and any BILAG B was only 3%. So there was not much active disease here. And there were a few post hocs where they looked at things that would predict reactivation. And it was some things I would kind of expect, so some like blood tests suggestive of more active or more severe lupus, like low C3 and low C4, or low numbers of lymphocytes. So my feeling with this one was that it does help answer my question, which is that in the 2 to 3 year duration of mycophenolate study, stopping after lupus nephritis, stopping seemed to not be a good idea. As things get a bit longer, when you look in this study, the risks of reactivation seemed lower and not significantly different with the ones who continued. And there were also, because of some of these post hoc analyses and things, you could also get the suggestion that if it's nephritis, you might have a tendency to go a bit longer on the mycophenolate. If they look serologically very good, you might be more inclined to consider tapering or stopping. There are some limitations. There's an open label study. Was the adherence great, which might bring the arms closer together if it wasn't? Does the demography of this group match my patient group in the clinic? And I think also the list of things that might affect your decision. They've looked at complement levels, lymphocyte levels. Did you have nephritis? They looked at a few, but the list of total things that might affect the success or failure of that decision is probably quite long, and you probably need to think quite carefully about specific situation. What did you think about this one?
Yeah, I mean, I think it's an important idea. I mean, I think given that there's not so many patients, and I was also drawn to the idea that although there overall was no big differences, that almost 3 times as many patients had problems with reactivation or flares in terms of the nephritis patients.
Yeah.
And so I just wonder what that would have looked like in a bigger study that was randomized.
Yeah.
So, I still think, this is very helpful to know that many patients can stop and have no problems. And I think it just takes the kinds of things that you're talking about, looking at serologies and knowing the patient's history to know, when can this be done?
Yeah. Infection risk to be balanced in there, I think, because
Exactly.
what a difference in that. And yeah, how you're going to monitor it, how you're going to control it. In the nephritis, the comment that they refer to in their discussion is that there's another study that showed a lot of these people who relapsed with nephritis actually still had inflammation in their kidneys.
Right.
Like on biopsies. Just because somebody feels well and has felt well for a long time, there could be quite a lot going on under the
Well,
surface.
I think there's a lot of truth in that. And also, I think what we typically think of as, okay, proteinuria less than 500 milligrams in the urine may not actually be correct. And you can probably find significant disease at lower levels.
Yeah.
And so I think we have a lot to learn in that area as well. And we may need to learn how to select the right patients who really don't have activity as much.
And I also think the other thing with these interventions is how you deliver the intervention. How are you going to monitor this closely? Does this
Right.
person know what to do, et cetera, et cetera? What have you got a rescue strategy if it goes wrong? All of that needs to be thought about as well.
Yes.
So I think that's all we've got time for today. So thank you for joining me, Vicky. It's great to hear your thoughts, as always, on these developments.
My pleasure. It's great to be here.
And thank you everyone for listening. As always, you can find the full slide decks for all of these papers at lupus-forum.com. So you can download those and use them in your journal clubs or your teaching. The whole of the Lupus Forum is free to access. All our content is free to download. And if you register for updates, then you'll get emails when there's something new out. And you can also look at Lupus Forum, or one word, on Twitter and LinkedIn. Thanks again, and see you next time.